Good morning, all. I'm Dr. Amar Nath, Senior Lecturer, Department of Oral Medicine and Radiology, MESDC College. Today, I'll be discussing about the topic trauma to the teeth. As you all know, trauma to the teeth is something very common which we come across in our daily life. So you can clinically you can evaluate the trauma, but you always need a radiological evaluation of the trauma. Like in case of fracture, you can see the fracture line. You won't be able to see the fracture line in clinically sometimes, but you can always see it in a radiological evaluation. There are some particular type of radiography which helps you to identify the fracture. In fact, so radiographic examination. Before radiographic examination, you should always go for clinical examination, which is very important. Okay, when you go when the first radiographic examination, there are two periapical films at different horizontal angulation can be used. Like it's very helpful in identifying the fracture. Okay? Two radiographs at right angles to each other. If you're suspecting a bone fracture, like in a mandible or a maxilla, always go for an extraoral view like OPG, CBCT, etc. You should go for chest and abdomen X-ray if a tooth or a foreign body is inhaled or swallowed. Like in some cases, like if you are in a road traffic accident and all, sometimes we just swallow the tooth. So if if the tooth is missing, you can always go for a chest X-ray or abdomen X-ray. Like chest X-ray, if it's inside the lungs, you can see it in the lungs, or if it's in the abdomen, you can see in the abdomen. Diagnostic information from radiographs. Okay, the main diagnostic information you get from a radiograph is the type of injury, site of fracture, the orientation of fracture, degree of separation or displacement of fracture fragments, stages of groove development, condition of the apical tissues, presence, site, and displacement of alveolar bone fracture, and the condition of adjacent or underlying teeth. Uh, the other diagnostic informations are like you get the evidence of healing, whether that the fracture is healing or not. Post-traumatic complications such as resorption, infection, cessation of tooth development. When there is a trauma to your tooth, the tooth might go non-vital, so it can cause resorption of the root. It can cause infection in the periapical region, like abscess or cyst or anything. Or if there is like the tooth is not completely developed, the trauma is on the not fully, it's on the not fully developed tooth. It can affect the development of that particular tooth. Okay. Next, the location of the tooth, if swallowed or inhaled, whether and the location of any foreign body. What are limitations? If the radiographic finding may be absent, because if the fracture line is oblique and X-ray beam cannot pass through it, you won't be able to see the fracture line. Okay. If the radiolucent fracture line may be present labially or palatally and superimposed over the pulp without actual pulp involvement, then also the fracture line is difficult to trace. Incomplete fractures may not be visible in the radiographs. Radiographic features of tooth fracture. Okay. A radiolucent line between the fragment can be seen. Alteration in the outline shape of the tooth. Discontinuity of the periodontal ligament shadow. Those are the radiographic features of fracture. Now, let's talk about some classification. The first one is by Bennett. First, traumatized tooth without crown or root fracture. That is, tooth firm in the alveolus or the tooth sublux in the alveolus. We will come to the terminals of fluxation, subluxation after a while. Okay. So next is the coronal fracture. That is the crown fracture. Crown, that is mainly the crown has enamel and dentin. So the first one is involving enamel, and second one is enamel and dentin. So the third one is like the next thing in the crown is the pulp. So the crown fracture with pulp exposure. Okay. Next is the root fracture. Root fracture without crown fracture or root fracture with the crown fracture. Okay. The fifth one is avulsion. There is complete loss of tooth from that socket. Next is Ellis classification of fracture. Ellis in 1970 classified fracture into 9 categories. The first one is only enamel is fractured. In class 2, enamel and dentin is fracture is seen. In class 3, enamel, dentin, and pulp fracture is seen. So in basically the first class 1 fracture, there won't be any tenderness. In class 2, since the dentin is involved, you always feel sensitivity. In class 3, since the pulp is also involved, tenderness is sure. The class 4 is non-vital tooth, with or without loss of tooth structure. The class 5 is complete avulsion of the tooth. And the class 6 root fracture, with or without loss of crown structure. Class 7, displacement of a tooth without fracture of crown or root. Displacement means the tooth is displaced from the socket, but it can be it is without the fracture of crown or root. And the class class 8 is fracture of the crown, whole crown end mass, complete fracture of crown. And the class 9 goes to fracture of deciduous. So some terminologies which you come across in trauma that we'll discuss about. First, we'll discuss about concussion. Trauma to the supporting structures without loosening or displacement of the tooth. This is called concussion. Okay. The main radiological feature is widening of the pedonal ligament space. Reduction of the size of the pulp chamber and root canal may develop months or years later. Okay. So here you can see the widening of the pedonal ligament space in this lateral incisor seen over here. This is due to concussion. Next is luxation. Luxation is the dislocation of the articulation of the tooth. Luxation comes, there are multiple classifications for luxation. It is in the first one is subluxation, second one is intrusive luxation, third one is extrusive luxation, lateral luxation, and avulsion. So what do you mean by subluxation? Subluxation is the injury to the tooth supporting structures that has resulted in abnormal loosening of the tooth without frank dislocation. That is, the tooth structures are injured, but without any, there won't be dislocation. Radiological features, mainly there will be widening of the pedial space. Okay. See over here, you can see the subluxation. That is, the tooth slightly comes out from the socket, but not in a proper way. But so the pedial space has enlarged. You can see over here the apex. This is called subluxation. Next one is the intrusive luxation. Intrusive means intrusive. The term suggests it goes inside. Okay. So displacement of the tooth into the alveolar bone. This is called intrusive luxation. The main radiological feature is that partial or total obliteration of the pedial space. You won't be able to trace the pedon ligament space since the tooth goes inside the socket. See over here, the tooth goes inside the socket. So you won't be able to trace the pedial space. So in this clinical picture, you can see the tooth goes inside the socket. It looks like a partially ruptured tooth. But just compare with the occlusal plane of the other tooth. It just goes inside, and the trauma. This is the trauma. In the radiological picture, see the tooth goes inside. You won't be able to trace the pedial space over here. Next is extrusive luxation. Extrusive luxation is the partial displacement of the teeth out of the socket. That is, the teeth is not completely coming out of the socket, but all partially it comes out. It's a radiological feature. Widening of pedial ligament space, pedon ligament space can be seen. Widening more at that apex, you can see a big, there will be a huge space in the apex between the tooth and the tooth apex and the over here laminar dura. Here the whole tooth is partial tooth has come out, so the space has increased. This is the extrusive luxation. Okay. Next is the lateral luxation. Movement of the tooth other than axial displacement. That is radiological feature. Increase in the width of the pedon ligament space on the side of the impact. So here the impact is from the palatal surface and the tooth moves towards the palatal surface. Okay. So wherever the side, from where the trauma is causing, which side the trauma causes, the tooth move towards that side. That is the lateral luxation. This is avulsion. It is a complete displacement of a tooth from its alveoli. That is, you won't be able to see the tooth inside the socket. Dental socket without tooth. If recently avulsed tooth, lamina dura will be more apparent. See in this radiograph, you can see the lamina dura, which suggests that the tooth has been recently passed. If the lamina dura is not seen, then you can go to the instance that the teeth has been lost for a while. Now here the lamina is not that apparent, so in this case the teeth has been lost for a while. Next is the crown fracture classification. Crown has enamel, dentine, and pulp. So fracture involving only enamel without loss of enamel structure is called infarction or crack. The second one is fracture involving enamel or enamel and dentine with loss of tooth substance but without pulp involvement. This is called uncomplicated fracture. Okay. And the next one is fracture that pass through enamel, dentine, and pulp with loss of tooth structure, which is called complicated fracture. Hood fracture can occur at any level. Hood fracture can occur at any level. The degree of mobility of crown relates to the level of fracture. The fracture closer to the apex means the tooth is less mobile. The fracture is closer to the apex, so still there will be a lot of supporting structures for the tooth. So that you won't feel much of a mobility on the crown. May or may not be associated with alveolar bone fracture. But always you can always differentiate the alveolar bone fracture and root fracture by palpatory method. Actually, if you are palpating the whole segment, the whole segment is mobile, then it's going to be a alveolar fracture. If only the tooth is mobile, then you can go to inference that it's a tooth fracture. There will be loss of sensitivity. Radiological feature: when orientation of the X-ray beam is parallel with the plane of a root fracture, sharp radiolucent line between fragments can be seen. If the orientation of the beam not through the fracture, then poorly defined gray shadows are seen. Non-displaced fracture, difficult to demonstrate. Over long-term calcification, obliteration of the canal or resorption can be seen. Like I said before, when there is a trauma, if you take a radiograph immediately, like that day or the next day, you won't be able to see any changes in the bone. You can always see all these changes after a while. But fracture lines can be seen. If you suspect a fracture, it can be seen easily. Like you see the root fracture over here. The middle third of the root is fracture. Over here also, you can see the root fracture. You can different diagnosis for this root fracture is soft tissue shadow of lip, halo of nose, nasolabial form. All these show as a thin radiolucent shadow, which can be confused as a fracture. This is a crown and root fracture. It involves both crown and root. Vertical root fracture. Vertical root fracture is commonly associated with endodermally treated tooth, while insertion of retention screws or pins, etc. The radiographic features are radiolucent line, widening of the pedon ligament space, diffuse radiolucent lesion along the side of the tooth towards the crestal bone, resembling pedonitis. Okay, so here you can see the root fracture over here. Or here also you can see. This usually happens during preparation of the canal, during RCT and all. So yeah, that will be for today. I hope you understand the fractures regarding tooth and the traumatic, and the terminologies regarding trauma. So yeah, thank you. See you next class.